series of talks. I had one, and it kind of stemmed from actually a dinner a couple nights ago that both Joaquin and Greg were there, and I think the consensus was that metal allergy doesn't exist. And I guess it hasn't necessarily been exactly my my personal experience, and I think part of it is that it would be nice to hear from you to see what your thoughts are of differentiating both skin testing versus blood testing, and that if there's a difference with regards to those in terms of being able to diagnose it. And obviously in the paper that was published, that was based on skin testing, and I would completely agree that that's probably useless. But is there value with regards to blood testing? And then in those cases, do you think it can actually identify patients with a problem?
So I'm not an expert at all on metal allergy in implants, and I think there probably are cases where they exist. But the origin of this study is because we do get a lot of patients, like probably all of you, that come and say, I have a skin allergy, I need an implant with no metal. So the study has limitations, obviously, because what we did is going through the medical records electronically, we found every patient that had a shoulder arthroplasty and had a clear history of a skin allergy documented by dermatology. Mm-hmm. Sometimes it was just based on an interview with the patient by the dermatologist. Sometimes they had also, in 13 cases, a skin testing. So the only thing that the paper shows is that the patients that we had on a replacement of the shoulder that had documented dermatology-diagnosed metal allergy did not have an increased rate of loosening or anything else. So it's a very rough way to answer the question. I don't think it answers the question, but I think it's fair to say that the majority of patients that have skin reactions will not have a problem if you use a conventional implant.
I would agree.
But I'm sure that there is some patients that do have true allergy. I just don't know how to identify them.
Mm-hmm. Have you ever used blood or no?
No, I haven't.
You haven't. Mark?
So Bob, one of the things that occurs to me is, when you're talking to a patient about risks and benefits, some of the risks become very obvious. If it's a very complicated case, you can talk about potential iatrogenic fracture, et cetera. But one of the things that happens is if someone comes in with a painful shoulder and it's not an obvious diagnosis, and now you're trying to really look for these zebras, there's a real risk that the patient may have pain, and she might have had pain no matter what. So the diagnosis, the confidence that you might have on truly identifying why this person has pain, if it's not very high, there's an inherent risk that you might do an operation that might be quite large, have a significant complication rate, which we've already heard about, and you don't really know if, in fact, that is the pain generator, because pain is multifactorial. So in my mind, I don't necessarily want to know if blood test or skin test are better, because I don't want to entertain the diagnosis because I'm working to it. Now, it's different if the patient tells me up front, I have an allergy, I'm going to use a nickel-free implant. But to see a painful arthroplasty and then say, oh, well, I think you have a nickel allergy, I just would feel uncomfortable with that. That would be my two
Have you ever, Mark, while you're there, have you ever revised the patient specifically for a metal allergy in your practice? Okay.
Nope.
Has anyone, it would be good to see a show of hands, has anyone had that experience where
Jerry Williams reported on 4 cases.
Yeah, painful arthroplasty, no other known etiologic reason for pain, diagnosis of metal allergy revised, and then symptoms improved after revision.
So Bob, you and I talked about this. I had a case where it's not an implant, it wasn't a total shoulder arthroplasty, but it was ORF of a humeral shaft fracture that I used a stainless steel plate on, and she developed a rash and blisters all over her skin. And I was like, no, this is not really a metal allergy. And I followed along, got the testing done, and they didn't go away. And then I removed the hardware, and all the skin blisters went away.
Right,
so
that's the delayed type hypersensitivity reaction.
So is that an allergy to metal then? Yeah, that's what I thought.
Did you culture that patient?
Yeah, so I worked her up for infection. It was just an approximate humerus fracture that I had fixed. I can't remember if I did.
What was her sensitivity on the blood test? How high was it? Did you get that result?
I can't remember that. All I remember is thinking that I didn't believe this existed and seeing the blisters on her skin, waiting for it to heal, taking them out, and everything went away. So you're probably right. Maybe I should have done some blood tests. I don't think I cultured I sent her to an allergist and let them make the decision whether they thought she was allergic or not. So I didn't do that myself.
And sometimes the thought is, there's such a low level of nickel in these metal implants and it's buried kind of deep within inside the metal, then can that really be what's causing it? I understand that. I've seen a cobalt allergy. And so for cobalt chrome, I mean, that's a majority of the actual physical implant that we actually use. And so I think that for whatever it's worth, I'm not sure, but I've definitely had at least 2 or 3 patients who are revised specifically for this, and they've had some improvement. Now, the question is whether or not that's due to that or something else. Buzz?
Yeah, I've got a patient now, and actually, Joaquin, hopefully maybe next year at the ASAP, maybe we can tell you what's wrong with this guy, but recurrent painless effusions, beautiful range of motion, real active guy, but recurrent effusions with 250,000 white cells in it. He's had scope, we've done tissue biopsies, never grown anything. All of his other parameters are totally negative. And when I went in the last time, only one time to go back in and just try to do a poly exchange, give him suppressive antibiotics, I just think with 250,000 white cells, it's got to be infected. But it's this lime green effusion. And yeah. So anyway, let me just talk about the color of the tissue in the shoulder was this light gray. It's not metallosis. It's not that black aggressive membrane, but it was just like this light gray. And this implant that I use is a hydroxyapatite coated implant, and it looks a lot like the color on this implant in terms of, so I'm wondering if, hydroxyapatite is something that occurs naturally in the human body, so you wouldn't think that people could be allergic to it, but I think that may be something else that we might need to figure out. It's, let Joaquin and the guys at the Mayo Clinic figure out what to do for him, because he's getting osteolysis. I mean, he's getting a negative response to whatever it is that's going on.
I think the thing is that at some level, from an arthroplasty standpoint, shoulder arthroplasty has obviously followed hip and knee arthroplasty surgeons for the past 80 years. And so from a level of, I know my own partners from a hip and knee arthroplasty standpoint, I have several that get metal allergy testing on every single patient that they do surgery. So if I think with regards to how we have done what we've done over the course of the past 40 years in shoulder surgery, maybe we might just reflect on that, and that if the surgeons that do hip and knee arthroplasty at least consider it as a possible diagnosis, then maybe there's some value. But Ludwig?
I want to switch the topic. I want to ask Chris about do you do a suprascapular nerve release or neurectomy?
No, on that patient, I basically excavated the nerve out as best I could. I did not do a neurectomy. I only would do that on a chronically painful patient that already had wasting of the supraspinatus and infraspinatus fossa, because that patient still had active nerve or muscle function. So I don't want to, decrease her potential range of motion. And again, we did it with the hope of alleviating her pain, because I told her other option would be, after seeing where the screw was, to take the replacement out.
I think this is important to mention. If you only have to teres minor, then you can do the neurectomy.
Yes.
Otherwise, you have to take out the implant. I have 5 cases, twice with screws, others with pegs high, which are clearly showing on the CT scan. They're going to the suprascapular notch and hitting the nerve, squeezing the nerve, and patients were pain-free right after the surgery if you took the hardware from the nerve. The nerve did not lack metal on them.
And I think that's actually something that's worth looking at in the stiff reverse as well, because those patients don't like to move, and then they stay contracted. And again, with the patient I pointed out, she had much improvement in her range of motion afterwards.
Brad, one last thing.
Yeah, I was just going to say the only value for me for the blood test is pre-op. So if a patient says they have a nickel allergy, I don't think the skin tests are valuable. I'll send the blood work off. The problem is it's not covered by insurance.
Right.
It costs $500, so it makes the patient buy into it, because I would prefer to use a prosthesis I use, commonly, and one I'm familiar with, and one that I think is going to fix their problem. And if you have to do an all titanium prosthesis, it may not be in the, the type you like.
Sure.
So.
Okay. And one little message, I think the bar's going to close in a couple, 5-10 minutes, so make sure you get your last beverage.